I want to thank each one of you braved this bad weather and who have come here on this really special occasion. The fifth Dr. K.S. Ranganathan. So, my name is Dr. Revati Raj, and it's my pleasure to welcome all of you to this special occasion here. We have legends talking about legends, and we will begin this evening with the Tamil Thai vibes. And I request all of you to please stand up for the Tamil Thai vibes.
நீராடும் கடலுடுத்த நிலமழந்தை சீராடும் கதவென நிகழ்வகத கசிறு இவை முதல் தனித்தனரும் திலகமுமே அந்திலக வாசனை போல் அனைத்துலகும் எத்திசையும் உடல் மறக்க இருந்த பெரும் தமிழங்கே பொன் சேர்க்கவை திறமையந்து செய்ய மறந்து பார்க்குமே பார்க்குமே
So again, thank you all for coming. Dr. Purna Chandran couldn't be here, so on his behalf,
sound coming. Check one.
Dr. Purna Chandran couldn't be here. On his behalf, it is my pleasure and honor to welcome each one of you to this gathering. We have some very fantastic special members who are present here. I want to extend my special thank you and warm welcome to Shri Rajagopal, who is the managing trustee of VHS, Mr. G.P. Ramachandran, who represents the Dr. K.S. Ranganathan family, our chief guest for today, Professor Dr. S. Subhash, who has come here specially to be part of this occasion, and the person we all love, admire, respect, and revere, Dr. S. Suresh, who's the Honorary Secretary of VHS and who is going to deliver the oration today. and also Dr. Maithili, who is the director of the VHS Blood Center, Dr. Nitya, and Mr. P. Atmanathan, without whose work today's occasion would not have got started at all. So I'd like to welcome all of you again and hope you enjoy the special evening as much as I feel I'm going to be enjoying, because this is a topic that not many people excel at and not many people can talk about, because the child is the beauty of God present in the world and the greatest gift that a family can have. And we're going to talk about that unborn fetus. I'd like to welcome all our special guests on stage, please. Sri R. Rajagopal, Mr. Ramachandran, Dr. Subhash, Dr. Suresh, Dr. Nitya, Dr. Maithili, and Mr. Atmanathan to light the Kutubalam.
Madam. Madam.
Thank you, everyone. With this one candle, we can light 1,000 lamps. And with this one oration, so much of information and knowledge has been dissipated through the year. And this oration has been special for the field of transfusion medicine and those dealing with blood disorders. I'd like to now welcome Dr. Maithili, Director of EHS Blood Center, to talk about why are we gathered here and what we do to remember Dr. K.S. Ranganathan.
Today, on the 3rd December, so birthday of our founder, Dr. K.S. Ranganathan, and also the first director of our blood center. I'm very happy to talk about him today. Dr. K.S. Ranganathan was a pioneer in the field of transfusion medicine as well as in BCG vaccination and was a great scholar and scientist, and was also a good teacher. And he led a very simple life and touched many people's lives. Born on 3rd December 1897, he got his medical degree. Those days it was called Registered Licensed Medical Practitioner LMD degree from Raipur Medical School. Then under Rural Health Services, he worked in hilly areas of Andhra Pradesh, and he helped many poor people, and he gave comprehensive health care to those patients with the limited facilities and limited transport that was available in those days. Then he went to England and got his MRCS, and he took special interest in the field of transfusion medicine. And he had very good opportunities to work with all legends of the field in the transfusion medicine. That is Paul Landsteiner. He's called the father of transfusion medicine and who got a Nobel Prize in 1900 for his major discovery of blood groups. Only after his discovery, there was a huge change in the field of transfusion medicine, and our founder, Dr. K.S. Ranganathan, had the opportunities to work with him, and also Dr. Alexander Wiener, who discovered this RH typing, and also other doctors and other Moran Coombs, and all of us who are in the microbiology field, they know about this famous Coombs test, and was the discoverer of Coombs test. So our founder had got all the opportunities, and he learned so many things from them. And then he came back to India and joined as assistant director of King Institute and organized the first blood bank services at the King Institute, Chennai. And then he also organized blood bank services in other places of the India. That is, especially during Second World War, and he trained many doctors and staff nurses and people in the field of transfusion medicine. And he worked a lot during the Second World War. And then he took training in at the State Serum Research Institute, Denmark, and also at Louis Pasteur Institute, France. And he founded the first BCG vaccination center in Indy, and he became the first director of the BCG vaccine laboratory. And when we visited to see the director of the present director of the BCG Vaccine Institute, and really I was very much thrilled to see our Dr. K.S. Ranganathan was the first name founder of BCG Vaccination Laboratory. Then after his retirement in 1962, he came to VHS to start the VHS Blood Center with the help of his friend, that is Dr. K.S. Sanjeevi, who is the founder of our VHS hospital. He requested him to start a blood center in VHS. Then he served as an honorary consultant in VHS Blood Center and started the VHS Blood Center with limited facilities and started all the manual techniques in those days. And he introduced all the techniques and sterilization procedures regarding the field of blood banking. And the VHS Blood Center was the first blood center in Chennai doing Coombs test, especially for RH negative confirmation and detection of RH antibodies. And all patients were referred, including government hospitals. They used to refer patients only to VHS. And all blood components like red cells, plasma, platelets, everything was separated, even when blood was collected in those days in bottles. It is very difficult to prepare component separation when we use bottles, but he was able to do so with his passion towards the field. And he did a research paper, and especially the incidence of RH factor in South India, and it was published in the famous journal Nature. And he also wrote a book that is Blood Grouping and Clinical Applications, with a highly commendatory foreword by Dr. Wiener, who discovered the RH group. And this was a crowning achievement for our founder, Dr. K.S. Ranganathan. And this book was, of course, considered as a Bible in those days. And then in 1968, Dr. J. Balasubramaniam, he joined VHS as a junior doctor to Dr. K.S. Ranganathan. And he was very much impressed by his senior Dr. K.S. Ranganathan's work. And Dr. KSR sent him for a training under Commonwealth Scholarship to UK. And he was trained well in UK. Dr. JB, he returned back to India. And with the joint project, that is with the Rotary Club of Madras Central and TTK, our blood bank was elevated. It was upgraded with all international standards and infrastructure, both by infrastructure and technology. It was upgraded on par with international standards. And today, our blood bank is a 24/7 blood center, providing blood transfusion services with all modern technologies. So right from the manual techniques, we switched over to semi-automated and fully automated technology. We are able to do 24/7 services to all the people in the society. And then in 2004, that is Thalassemia Welfare Association was started with the help of Dr. Revati, who is a pediatric hemato-oncologist. We started a Thalassemia Transfusion Center. To start with, we had some 5 patients. Today, we have got 250 patients who come to us regularly once in 15 days for regular blood transfusion. So all patients are getting not only for blood transfusion, they are getting comprehensive care in our Thalassemia Transfusion Center, DHS. And then we had a mobile bus unit that was started in 2014 under the Rotary Club Merasis. They came forward, and we got a very technical mobile bus. That is, within the bus, we can conduct the entire camp itself. So this is very useful. We go to very remote places where people don't have space to conduct the blood donation camp. We are using this mobile bus. And then regular training programs and regularly conducted for doctors, technicians, and staff nurses and medical laboratory technology students. So to say in short words, that is our blood bank in 1964 started by our founder Dr. K.S. Ranganathan. We had a very small unit, 4 to 5 people. People worked hard and brought up and developed our blood center. Today, our blood center, we have got 45 people working tirelessly 24 hours and helping all the patients, especially thalassemia patients. So it's a matter of pride and privilege for us to work in the Department of EHS Blood Center, which Dr. K.S. Ranganathan founded years before. So thank you so much patiently observing talking about Dr. K.S. Ranganathan. Thank you so much.
The family of Dr. K.S. Ranganathan is being represented today by Sri Ramachandran. He is the founder of today's endowment, and it's attributed to his late wife, Dr. Hema Ramachandran, who was the granddaughter of Dr. K.S. Ranganathan. She was a nationally acclaimed physicist, a leading figure in quantum physics in India, and her efforts contributed to the Indian Cabinet's approval of the 6,000 crore Quantum India project in 2023. She achieved an exceptional academic and scientific career despite significant health challenges. During a visit to VHS, Mr. Ramachandran was deeply impressed by the blood center's contributions, especially to patients with thalassemia. He was inspired and he established this endowment in the honor of Dr. K.S. Ranganathan, fulfilling Dr. Hema's wishes and preserving her legacy too. So today we are not honoring just one legend, but 2 legends from the same family who have contributed to our society and who are still continuing education in the form of this endowment. I'd now like to request Sri Rajagopal to honor Mr. G.P. Ramachandran and to appreciate all the efforts that the family have put in towards the blood bank and towards education.
Photo. Photo.
Now I'd like to request Mr. Ramachandran to give a short address to us about why this oration is so important to him.
Respected dignitaries and dais, ladies and gentlemen. The director of the blood bank, Dr. Maitri, has profoundly spoken about the pioneering work of Dr. Ranganathan in the field of vaccine science and transfusion medicine. Our Master of Ceremonies, Dr. Revati, has spoken eloquently about my wife and her contribution to the development of science in India. I have been talking about the genesis of this memorial lecture several times in the past. This is the 5th memorial lecture. But for those who are appearing for the first time, I'll very briefly tell about the genesis. The genesis can be traced to my wife, late Dr. Hema Ramchandran, whose accomplishments has already been spoken to you. So to perpetuate the memory of my wife, I was wanting to institute grants in reputed institutions in the field of research. The first institution which came to my mind was BHS, because of the close relationship of my family with BHS. So I came and met Dr. Suresh with the mind to create a corpus, especially in the field of research, because my wife was basically a scientist. So he, the first time, took me around to the blood bank, and I was extremely impressed about the facilities and functioning of the blood bank. Especially, I was touched by the thalassemia ward, which the PHS blood bank was doing a great service for the children who have been affected by thalassemia. So I immediately put a question to Dr. Suresh. How we are honoring the founder, Dr. Ranganathan, in VHS? He said it is a responsibility of the family to perpetuate his memory. I readily accepted, and whatever amount I had in my mind as a grant, I decided to divide between research and this one, and to perpetuate the memory of Dr. Ranganathan. So then the question came, how he has to be honored. So, a fine suggestion came from Dr. Suresh, the secretary, that we could conduct a memorial lecture every year on his birthday, and thus was born this memorial lecture. I am extremely, I have a sense of gratitude I have for the PHS management, and especially the management of blood bank, for taking the onerous task of arranging this commemorative function. I mean, it's quite a onerous task, because you have to organize the speaker, you have to organize the chief guest, you have to take care of the logistics, you have to take care of all other arrangements to make the function successful. And they have been doing wonderfully well for the last 5 years, and I express my gratitude to them. I have only one small suggestion to make. In the report of VHS Blood Center, beneath that, it says, in the memory of Dr. Ranganathan. My suggestion is, word can be added as founder, thereby conveyed in the memory of the founder, Dr. K.S. Ranganathan, so that it becomes meaningful for the onlookers of the PHS platform. Thank you. Thank you.
Good.
Thank you so much, sir. We will definitely honor your request that you have put in, and we know how passionate you are about this oration, and we'll continue doing a lot more. So we have a very special chief guest today, Professor Dr. S. Subhash. And Dr. S. Subhash is a senior expert in the field of transfusion medicine. He's working as a professor and head of the Department of Transfusion Medicine at Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai, for the past 20 years. He has held several leadership roles and contributed to the scientific community through clinical research in areas such as platelet transfusion and therapeutic plasma exchange. In 2021, he also held the additional charge as Joint Director, Blood Safety at the Tamil Nadu State AIDS Control Society, TANSACS. He served as the organizing chairperson of TransMedCon 2024, the 12th annual National Conference of the Indian Society of Transfusion Medicine. I think it was very special that he was the first guest to arrive, and rarely we see the chief guest coming as the first person to the event. Thank you very much. We're really honored to have you here, and we'd like to welcome you to say a few words to the gathering.
Greetings to all. Inspector Mr. Gopal, Managing Trustee of the Voluntary Health Services. Respected Dr. P. Maitri, Director of VHS Services. Respected Dr. S. Suresh, our esteemed orator and Honorary Secretary of VHS. Honored by the members of the respected K.S. Ranganathan family and my teachers, Professor K. M. Radhakrishnan, Professor Nagartha Sikilo, and distinguished guests, colleagues and students. It is a profound honor to stand here today at the 5th Dr. K.S. Ranganathan annual oration, the heart of the esteemed institution, the Voluntary Health Services. We pause first to remember Dr. K.S. Ranganathan, a name synonymous with the dedicated, selfless services. His vision, spirit, and commitment to healthcare are the very foundation upon which the VHS Blood Center is built and thriving well till now. Events like this annual oration are not just memorials, they are living testaments to his legacy, inspiring the next generation to pursue excellence in medical services. To the family of Dr. Ranganathan, who are privileged to honor today, thank you for sharing his legacy with us. Today's oration will be delivered by respected Dr. S. Suresh, who is focused on diagnosis and management of fetal anemia, a topic that sits right at the intersection between maternal health, neonatology, and transfusion medicine. The challenge of fetal anemia, often manifests as hemolytic disease of the newborn, is a crucial battleground in saving any lives. It requires precise diagnosis, timely intervention, and the highest standards of blood safety and immunohematology. Dr. K.S. Ranganathan was not merely a founder, he was a visionary pioneer of transfusion medicine in India. The VHS Blood Center, founded by Dr. K.S. Ranganathan, serves as a vital institution dedicated to ensuring a safe voluntary blood supply and upholding the high standards of quality in transfusion medicine. It provides specialized support, particularly in immunohematology, for the thalassaemic children and the preparation of advanced blood components necessary for complex cases like fetal anemia management. I urge all of you who are present today for us to take inspiration from Dr. Ranganathan's life. Thank you, Voluntary Health Services, for your endless pursuit of excellence and for sustaining this platform. I look forward with great anticipation for the address of respected Dr. Suresh sir, and there is no one better equipped to highlight this critical area, diagnosis and management of fetal anemia, than our esteemed orator, Dr. Suresh, Director of Mediscan System and Honorary Secretary of VHS. May the spirit of service and the dedication to saving lives continue to defend the voluntary. Thank you all.
That was just perfect, sir. Short, sweet, and right to the point. Thank you so much for your kind words. I'd like to request Sri Rajagopal to please honor our chief guest, Dr. S. Subhash. We're giving these with our best wishes so that you will give the gift of life to so many patients who are in need.
I will be failing in my duty if I don't mention about the successors to Dr. Ranganathan, Dr. Dr. J. Balasubramanian, and Dr. Maithili, who have helped in raising this blood bank to great heights. Thank you.
As Dr. Subhash had said, these are tiny, tiny little beautiful life forms within us, a fetus. And to deal with blood transfusion for a fetus, it is a very specialized niche area. And we are now going to see what the pioneer in this field has been done. But to set the stage of why we needed fetal medicine, why did we need to correct fetal anemia, I'd like to call upon Dr. Nitya to just share 2 to 3 cases that we have dealt with here, the challenges that we face, and then you would be able to understand what to what extent Dr. Suresh and his team have worked to bring this field so far ahead, on par with the rest of the world, and sometimes I would say above par. And it's actually an amazing story. I don't think many of you realize or recognize. So I'd like to call upon Dr. Nitya to just set the stage to say what are the types of cases we deal with before we listen to the oration.
Thank you, ma'am. Good evening, everyone. I'm myself, Dr. Nitya. I'm a senior registrar of VHS Blood Center. I know we are now eagerly waiting for the annual oration by our Dr. Suresh. Don't worry, I won't take much of your time. Well, here I present you some unusual immunohematological case scenarios we see in hemolytic disease of fetus and newborn. In case number 1, we received a blood sample of antenatal mother from Mediscan for antibody screening as we found the evidence of fetal anemia in recent daughter in a background of negative Coombs test. Mother is in her gravida 2. Mother blood group is ORHD negative and father blood group is ARHD positive. The gravida 1 is uneventful since baby being O positive, anti-D injection was given after delivery. At the time of evaluation in gravida 2, the mother is 33 weeks of gestation. Her middle cerebral artery peak systolic velocity of the fetus was high, and the chordocentesis revealed the fetal anemia of 8.5, and subsequently intrauterine transfusion was done. To us, mother and pre-transfusion fetal blood sample was sent for evaluation. The immunohematological workup on mother confirmed the blood group as ORHD negative, while other tests like indirect Coombs test, direct Coombs test, autocontrol, and antibody panel testing were turned out to be negative. So the negative Coombs test signifies the absence of both allo and auto antibodies in the mother's serum. Even though the mother is RHD negative and father is RHD positive, this mother doesn't develop any RH antibodies. So the only immunological cause of fetal anemia in this case could be ABO-HDFN. ABO-HDFN occurs when a mother is of O blood group and father is of A or B blood group. The naturally occurring IgG anti-A and anti-B in the mother crosses the placenta and attack the A or B antigens in the fetal red blood cell, producing the HDFN. But ABO-HDFN is often mild, right? Will it cause a fetal anemia requiring intrauterine transfusion? So to check out the possibility, we did a ABO titration of TTT treated maternal serum, and the IgG anti-A titer was found to be 16,384 and the IgG anti-B titer was found to be 128. So this high anti-A titer almost points to the diagnosis of ABO-HDFN, but we can't confirm the diagnosis until we identify the antibodies in the fetal blood which is causing hemolysis. So we got to have that chance as well. With the help of Dr. Suresh, we got a fetal blood sample just before intrauterine transfusion. On testing it, the fetal blood group was identified as ARST positive and DCT was found to be 4+ in the fetal red blood cells. So next step is to identify the antibody. The process of removing the antibody from DAD positive, that is direct test positive red cells, is called as elution. There are different types of elution available. The ideal one to check the ABO-HDFN is heat elution. Since we have a glycine acid elution method in hand, we tried that as well. So the antibody eluted by these two methods reacted only with the A cells, confirming the antibody causing hemolysis as anti-A, and the cause of fetal anemia was confirmed as ABO-HDFN in this case. So these are the few cases from the literature where the ABO-HDFN is presenting as neonatal anemia with hyperbilirubinemia, requiring the intervention of exchange transfusion, IVIG, and blood transfusion. But our case is a little bit peculiar. Here, the ABO-HDFN is severe enough to cause a fetal anemia, requiring the intervention of intrauterine transfusion. These studies also teach us that high maternal antibody titers of more than 512 are strongly associated with ABO-HDFN. So the take-home points are the ABO-HDFN, though often mild, sometimes can be severe as such in our case, but it's not rare and may go unnoticed without proper screening. So the antenatal IgG antibody titration in O group mother is a low-cost and effective method to identify high-risk pregnancies, and routine DAT testing, that is direct test testing in all O group deliveries, can help to detect at-risk newborns early. And final point will be the institutional delivery and follow-up for O negative mothers with high titers is essential to prevent severe neonatal outcomes. So moving on to our case 2, here both the mother and father were RSV positive, but they had an incompatibility during the cross-match testing while receiving units for delivery. So post-delivery, we received a sample of a mother for antibody evaluation. Mother is in her third pregnancy. First pregnancy presented as intrauterine death. Second pregnancy was uneventful, but baby had a history of jaundice at the time of birth. And at the current presentation, in the third pregnancy, mother delivered a live female baby. Mother had a history of anemia during pregnancy, but evaluation is not done. So on further evaluation, the blood group is confirmed as ORST positive. Unlike the previous case, here all the other tests of direct Coombs test, indirect Coombs test, auto control, even the panel testing were turned out to be positive. Here we need to note down two things. One is pan-agglutination in the panel testing, and the strength of agglutination in the ICT is more than compared to that of a DAT. So these 2 points suggest the presence of both auto and allo antibodies in the maternal serum. So this presence of auto antibodies, we couldn't identify due to the interference of these auto antibodies, we couldn't identify the specificity of allo antibody. So we requested a newborn sample for the further evaluation. Newborn also had a history of jaundice since birth, measuring to about 22 milligram per deciliter, and the direct Coombs test turned out to be positive in the baby as well. So as the previous case, we eluted the DAT positive red cells using glycine acid elution method, and the antibody elute showed a pattern of reaction unlike the reaction in a mother serum. And we identified the antibody as anti-JKB antibody, and the child was identified with anti-JKB HDFN. So the anti-JKB HDFN was first presented or first reported in 1958. Till now, there were 48 blood group system identified so far. Out of it, ABO and RH are considered as a major blood group system, and remaining 46 are considered as a minor blood group system. The KIT blood group system is one of the minor blood group system, and its two main antigens are JKA and JKB. And these two antigens can be detected as early as 7 weeks of gestation in fetal red blood cells, and they are completely developed at birth. So the frequency of JK, A positive, B minus phenotype is around 28 to 35% in Indian population. So when the JKB antigen enters into a patient with this particular phenotype for the very first time, it is rarely associated with a clinical significant disease. But on subsequent re-exposure of similar antigen, there is a strong anamnestic response producing a severe disease in the fetus and newborn. This is a recent article from a Northeast Indian study on a prevalence and specificity of red cell antigens, where 8,600 patients were screened for alloimmunization and 65 were found to be alloimmunized. So out of 64, only one case of JKB antibody is documented, and one other case of JKB was seen with anti-S antibody. I'm quoting this article to say that rare occurrence of anti-JKB HDFN. Till now in literature, there were only 14 published cases of anti-JKB HDFN, all presented at the time of at the term, and most of the cases recovered without the treatment, while few required the phototherapy and exchange transfusion. And almost all the HDFN children had a good neonatal outcome. Coming to our case also presented at the term, had a jaundice during delivery and recovered with the phototherapy and exchange transfusion, and also had a good neonatal outcome. So the take home points on this case are HDFN due to anti-JKB antibodies are relatively rare but can occasionally present as a severe disease requiring exchange transfusion. Here I emphasize doing antenatal ICT screening, which especially for the women with bad obstetric outcome and the child with adverse neonatal outcome, to rule out the HDFN due to minor blood group antibodies. And the very peculiar nature of KIT antibodies are, they are known for their often becomes undetectable over a pregnancy or transfusion is removed. Therefore, a detailed transfusion and obstetric history becomes vital in a case of KIT antibodies, even if the current ICT is negative. Otherwise, we will miss the KIT antibodies. Moving on to the final case, the case number 3. Here we had a newborn sample for the DAT evaluation, with both the parents being homocystinuria carriers and RHD negative. The baby is 3 days old, born of LSES, and the baby is also confirmed to be a homocystinuria carrier, born with a hyperbilirubinemia of value 21 mg per deciliter. Here, the mother's previous 3 babies of the mother died during the neonatal period, but the ICT evaluation of the mother was not done during the pregnancy. Both the mother and the baby is confirmed to have a group of ORHD positive. So in the newborn sample, the direct Coombs turned out to be positive. So that positivity signifies the human antibodies coating the newborn red cells and are causing the hemolysis. So to identify the antibody, we requested a mother blood sample and we evaluated in it. So the mother's ICT was turned out to be positive and antibody is identified as small c. And the baby is diagnosed with anti-small c HDFN. We all know capital D is the most immunogenic antigen of RH blood group system. Even a 0.5 ml of D positive RBCs can produce antibodies in D negative patients. Next to D antigen, the most immunogenic one is the small c antigen. Since most of us have a small c antigen, the occurrence of anti-small c antibodies are relatively rare. The literature states anti-C comprises around small fracture of aluminization of around 2 to 3%. But anti-C can cause a clinically significant HDFN, although the severity is variable. If the anti-C is combined with other antibodies like anti-C plus anti-D, anti-C plus anti-E, it can produce more severe outcomes. Even isolated cases of anti-C can also cause a severe disease, but those are relatively rarer. Here, I want to highlight that antenatal ICT screening is very crucial, especially in women with bad obstetric outcome. Because with a simple immunological test, we would have picked the fetal or a neonatal anemia in this particular neonatal or a fetal anemia, which went missing in this case. So thank you all for the patient listening. These are my references, and I now invite Dr. Revati ma'am to take over.
Thank you, Dr. Nitya. I think the whole teamwork between Dr. Suresh's team and Dr. Maithili's team here to find out what went wrong with the babies and how we can help them was highlighted here. We now come to the most important part of today's event, the presentation of oration, medal, and citation. I know all of you know about Dr. Suresh, but it is important that I introduce you all to who he is. Although for me, as I said earlier, this is somebody that I have always respected, followed what he has done, and not just in the field of medicine, but as a person, the compassion and all the kindness, and to think about what others need. He's a very unique person. So Dr. Suresh is a pioneer in the field of fetal medicine and prenatal diagnosis in India. He established the Mediscan systems, one of the country's foremost centers for fetal imaging and therapy. He introduced intrauterine transfusion and invasive fetal therapy techniques in India. When you listen to his talk, you will understand how difficult this is to give transfusion to a little baby who's moving all around in the womb and how tiny they are. It is an amazing thing that he does. And not just himself, but he's mentored hundreds of clinicians in fetal medicine. He's in fact the father of fetal medicine in the country. He has over 4 decades of experience, numerous publications and national awards, and he continues to lead advancements in fetal therapy, ensuring early diagnosis and treatment of high-risk pregnancy. So I'd like to call upon Dr. Maithili to please read the citation and present him the oration medal, please.
Professor Dr. Suresh, Director of Mediscan Systems in Chennai, is a visionary pioneer who transformed the landscape of fetal medicine and diagnostic ultrasound in India. He founded Mediscan in 1982, establishing one of the nation's earliest and most comprehensive center for fetal imaging, fetal therapy, and clinician training. He is the Honorary Secretary of Voluntary Health Services, Chennai, and he also serves as a visiting professor of perinatology, Sri Ramachandra Medical College, Chennai, and PhD Hospital, Coimbatore. A recipient of the prestigious FRCOG honorary from the Royal College of Obstetrics and Gynecologists, London, and the Doctor of Science from Dr. MGR Medical University, Dr. Suresh stands among the most respected leaders in maternal fetal medicine. He currently serves as Treasurer and Trustee of the International Society of Ultrasound in Obstetrics and Gynecology and contributes globally as ISUOG's ambassador to India. As Professor of Practice at IIT Madras, he brings cutting-edge clinical expertise into the academic and research environment nurturing the next generation of clinicians and innovators. A master clinician and teacher, Dr. Suresh, has performed over 25,000 diagnostic and therapeutic fetal procedures, including advanced fetoscopic interventions with training from the renowned Necker Hospital in Paris. His commitment to capacity building is extraordinary, having trained more than 5,000 doctors from India and abroad, authored over 100 publications and 2 books, and delivered over 800 lectures and 19 orations around the world. Through the Fetal Care Research Foundation, he has also extended specialized care to underserved communities, demonstrating a rare blend of scientific excellence and social responsibility. Recognized as a champion of Chennai by KSA Trust in 2018 and honored with Governor's Think to Dare Award in 2025, Dr. Suresh continues to be celebrated for his path-breaking contributions to fetal medicine, maternal care, and medical education. Beyond his professional brilliance, he is admired for his passion for nature and wildlife photography and his pursuits as an amateur radio enthusiast, a reflection of his curiosity, creativity, and multifaceted personality. The Voluntary Health Services and the Department of Transfusion Medicine feel deeply honored that the fifth Dr. K.S. Ranganathan annual oration on diagnosis and management of fetal anemia has been delivered by Dr. S. Suresh on Wednesday, 3rd December 2025 at KSNGV Auditorium, Voluntary Health Services, Chennai. So I'm really very happy and privileged to read his oration about our Order Secretary, Dr. S. Suresh. I think he doesn't need any introduction or even oration, anything, because he's internationally, he's a renowned person. Everybody knows about him, especially when somebody thinks about pregnancy, immediately Dr. Suresh face comes to every person, I think. So thank you so much, sir, for please.
We're really proud and happy that you've accepted to do the talk today. And we're looking forward to listening to your talk on how saving one tiny life saves the entire family.
afternoon. Distinguished Chief Executive Dr. Subhash, our beloved Managing Trustee, Gopal, the Ramchandran, Dr. Maitri, Nathan, Radha Krishnan, the Director Dr. Thomas, and friends who have gathered here today. First of all, thank you very much for this unique honor. I think this is the longest citation I've ever given. Thank you very much for the kind words. Another nostalgic moment for me here is when I joined VHS in 1976. One of the first places I went to, even though I joined the surgical department, was the blood bank. Dr. Jayapal was there. I took an immediate liking to how they were doing the blood groups, and I volunteered to go to blood camps. So he was quite happy. Anytime there was a blood camp, he would give me a call, and I used to go to the blood camp for collecting the blood. So we have come a long way from that. The blood bank is one of the finest blood banks you can ever see, and constantly working to better themselves, which is, I feel very proud as part of the VHS and being honorary secretary. I feel it's a blessing for me to be here. Today, I'm going to talk to you about diagnosis and management of fetal anemia. Somewhere along the line, even though anemia, the issue of anemia has existed ever since pregnancy came, it was sort of recognized in the 1960s. And the 1990s, 1995, there's one picture which I'm showing here, which is a picture of a Doppler, changed the entire face of the management of these cases, where the survivability of the fetuses went from 30% to 95%. And for the first one measurement and one extraordinary individual, I'll tell about him as we go by. So I'll just start with a little bit of an introduction, then I'll tell you about what is hemoglobin, etiology of fetal anemia, and diagnosis, prenatal treatment options for both immune and non-immune anemia. Let's some newer trends which are happening and also take on measure. So let me give you a few case scenarios. This 27-year-old third gravida, RH negative, first pregnancy with running full, 4 years old. Second pregnancy, intrauterine demise at 30 weeks. The cause was not identified. Present pregnancy, 27 weeks, present with severe fetal anemia diagnosis. The second is a 30-year-old, gravida 4, para 3. She doesn't have a live child, she's RH positive. First, second, third pregnancy, severe head drops, 24, 26 weeks, termination pregnancy done. Fetal anemia diagnosed in all pregnancies, but nobody had a solution. 24-year-old primary Eva had a fever in early pregnancy, presents at 20 weeks with severe fetal anemia. These are different scenarios where we feel. The first one is RH examination, the second was non-immune anemia, and third was possibly fetal infection. So first and foremost, even though we talk of RH and midway, only 10% of all fetal anemias are due to RH. 90% are due to non-immune causes, and there's a variety of causes there. Now let's go back and look at fetal hemoglobin. As we know, the adult hemoglobin, we have alpha 2 and beta 2 genes. There are two alpha genes and beta genes. And the fetal hemoglobin has alpha 2 and gamma 2 genes. And at levels at birth, you see that the fetal is about 70 to 80%, and levels in adults is less than 1%. Now, the median fetal hemoglobin, how much should it be? For adults, we know you can go and test our hemoglobin. By 18 weeks, it's about 10.6 grams, and by 40 weeks, it's about 13.8 grams. This is median. And why we need to describe the median is we need to define what is fetal anemia. It's we convert the median, these measurements into multiples of median or MOMs. We call it a mild anemia when the hemoglobin is 0.83 to 0.65 MOM. Moderate anemia when it's 0.64 to 0.55, and less than 0.55 equals to severe anemia. Now, if you take a fetal blood sample and send it to the fetal hematocrit, a hematocrit of less than 30% is considered as significant. And a hemoglobin of less than 7 grams is severe anemia, and hemoglobin less than 5 grams, there's a risk of fetal high drops. Or if there is high drops, for ultrasound, I presume the hemoglobin is going to be less than 5 grams. Now, immune cause of anemia is at about 10%, where effective anti-D prophylaxis have been implemented. That is, in areas where anti-D prophylaxis activity has been implemented, the immune causes are less than 10%. But in those areas where we don't have anti-D prophylaxis given, the number still seems to be quite large. So out of this, RHD appears to be the maximum. RH, little c, big C and D, and atypical antibodies like calcium and K are also being shown. Now, on the other hand, you have non-immune anemias. About 1 in 1,000, 3,000 pregnancies, several causes, infection causes, especially CMV and parvovirus, fetal hemorrhage, placental causes like chorioangioma, monoclonal twin pregnancies with twin anemia or polycythemia sequence, and cephalopolycyl teratomas. Genetic cause of anemia, these are hereditary alpha thalassemia, hereditary spherocytosis, and congenital dyserythropoietic anemia. And we also have fetal AP malformation, like a vein of Calvin malformation in the brain, or any other AVMs like hemangiomas can cause fetal anemia. Now let's go to immune anemia first and look at the Indian scenario. Rh negative pregnancies are about 5.2%. As varied prevalence reported from different parts, the prevalence of immune anemia in India is about 1.1 to 3.1%. Considering we have 28 million births, you can understand the burden of this. They're spread all over the country. Routine antenatal prophylaxis is not universal in India. More than 70-80% of them do not receive antenatal prophylaxis. And several cases of isoimmunization are seen even after anti-D administration. And possible causes, one, an ineffective dose has been given, or the efficacy of the drug. If you go to rural areas where the pharmacies are storing the medicine in the fridge, that sometimes they have 8-hour, 10-hour power cuts and not enough backup is available. So this is since anti-D injection is heavily dependent on maintaining a cold chain, ineffective vaccination is possible. Now, what are the sensitizing events for women in pregnancy? Uterine evacuation, like miscarriage, molar pregnancy, any pregnancy loss after 12 weeks, which either could be a spontaneous miscarriage or intrauterine or stillbirth, external cephalic versions when they do when they want to turn the baby from a breech to cephalic or delivery, abdominal trauma, and delivery regardless of the mode, either cesarean delivery or normal delivery. There is an intense fetal-maternal hemorrhage that happens at that point of delivery, and that's why we need to do the anti-D about 72 hours after birth. The sensitization is identified by the indirect stress. But what does actually signify? It detects the presence of antibodies against circulating red blood cells in the body, which then induce hemolysis. You have the direct stress where antibodies are attached directly to the RBCs, and you have the indirect stress where it detects the unbound antibodies in the RBCs. So when the antibodies are attached to the RBC, this happens in the fetus, and that's how you get hemolysis. So you do the direct stress in the fetal blood and the indirect stress in the maternal blood. But also important by what technique the test has been done. We have the column or gel augmentation method, which is more sensitive. It needs a smaller sample volume and it's reproducible. The tube augmentation method is a critical titer we have established for tube method is 2 to 3-fold higher for gel method. For example, 1 in 16. If it's in the gel method, you have to use 1 in 64 in the tube method. Now, the titer below which no significant hemolysis is expected to occur is 1 in 16. So if you have a titer of 1 in 8, then we are going to watch this pregnancy to see whether the titers are increasing or not. Now, higher the denominator, higher the antibody load. 1 into 256 naturally is much higher than 1 in 8 or 1 in 16. So the antibody load is expected to be higher. But we are talking about RHD all the time. But it's very important that we have a full antibody profile that needs to be done for all patients because you can divide them into 3 groups. Group 1 is commonly the anti-D, CE, so on and so forth, are commonly associated with clinical HTFN. Group 2 may cause a positive direct antibody test, direct test, and group 3 not documented to cause clinical HTFN. So you recently Dr. Nitya presented about the JKB, which you've seen, it's the direct test was positive, but the mother and indirect was negative. So our approach, first isogenized pregnancy. You do the ICT titer. If it's less than critical titer for that method, we repeat the titer in 2 weeks. If it is more than critical titer for that method of rising titer, we do ultrasound surveillance. Now there's a distinct change in our approach. Now, if you see a prior affected pregnancy, you do the ICP titer. Again, you can use the same algorithm, less critical titer, then you repeat the titer, so on and so forth. But we have moved away from that. What we do is, in the prior affected pregnancy, we do only ultrasound surveillance. We don't keep repeating the ICP titers because the MCA velocity is going to be much more sensitive for us to identify fetuses which require treatment. So here's the case of G3, P1, L1, A1, first pregnancy, spontaneous miscarriage at 8 weeks. The question comes, should we do MTD now? Or if so, what should be the dosage and what does the guidelines say? Now, whenever the gestation is less than 12 weeks, a minimum dose of 250 interaction units is given. Between 12 and 20 weeks, 250, and greater than 20 weeks, 5 interaction units is given. The fetal hemorrhage test, which I tell you what the test is all about, we don't need to do before 12 weeks, before 20 weeks, but after 20 weeks, yes, it's better to do it. A second pregnancy, this patient had an alive and well baby, and she had anti-D was given after delivery. So now the question is, WHO and ACOG have said anti-D IG should be given to all non-sensitized RHD women, negative women, having a therapeutic termination pregnancy, whether by surgical or medical method, regardless of gestational age. And here, the word non-sensitized RHD negative women. That means if her course test is already positive, then there is no point in giving the anti-D injection. The RCOG Green Top guideline says a Clifford Bentley test should be performed within 2 hours of delivery to identify RHD negative women with a large fetal-matrix level to require additional anti-D IG. Now, I can tell you straight away, no one does Clifford Bentley test in our place. Now, we are ours the only center which has been doing Clifford Bentley test for a very long time. It has got specific use, show you some examples of how we made fetal diagnosis using the Clifford Bentley test. And I'm hoping that some lab will provide it as a standard. Because it's a very simple test. It takes hardly 15 minutes to do that. In a case of suspected fetal hemorrhage, it can also quantify the amount of fetal blood that has gone into the mother's circulation. You can quantify the amount of hemorrhage, and that helps us a lot. Because if the quantity is more than 15 ml, then this baby is significantly anemic and would need to be treated. And when it goes more than 30 ml, it can actually result in infant and demise. So it's a simple test, as you can see. This is the RBCs. Once you do an acid elution, the maternal RBCs look like ghost cells. And if fetal cells are present, they stand out as red cells, very obvious. So per high power field, you can count it, and then there's a calculation and quantify the volume. Now she comes for the third pregnancy, the same one, and the screening test was high dose for trisomy 21. So she has to have a CVS. Now her group test was negative. She needs to have an invasive testing now. And so naturally, when you do the invasive procedure, we have to give an anti-D after the procedure. Now at 16 weeks, the patient reverts back for a second opinion, and now ICT is positive. Now what happened here? The antidote was given at the appropriate time, and her doctor decided to do an ICT test. Is this now a isolated pregnancy? This is a very important question that needs to be answered. But we repeated the ICT at 22 weeks, it has become negative. So how is it possible that a positive Coombs test can actually become a negative? The reason is ICT should not be done for at least 8 weeks after giving anti-D injection. What the ICT picked up was the antibody which was given by the injection, and that remained in the body for about 6 to 8 weeks. So only after 8 weeks it should be done. Now, a word about anti-D prophylaxis. Routine antenatal anti-D prophylaxis is recommended at 28 weeks as a single dose, or at 28 plus 34 weeks with a pre-dose screen. So, and postpartum, 500 international units, baby is D positive, and with a cord test plus vitamin plus a chiropractic test within 72 hours. In special cases where you give 500 international units, you do a C-section cell salvage, you can go up to 1,500 units when there is fetal hemorrhage. Now let me come to the diagnosis of fetal anemia. The earliest diagnosis of fetal anemia, I'm talking about the 60s, was the amniotic fluid bilirubin. They were estimating the amniotic fluid bilirubin. Obviously, because when the baby had hemolytic disease, the bilirubin was being extracted in the baby urine, and that was coming into the amniotic fluid. So the optical density of the amniotic fluid bilirubin at delta OD at 450 was the one which was used for diagnosis of fetal anemia, and they divided that into 3 zones: zone 1, zone 2, and zone 3. And they said, and the zone 3 is very severe, and the baby is extremely severe. Zone 1 they call it as mild. In reality, this was done by Professor William Riley, and this was part of the Riley's curve. Now, the Riley in the year 1963 in Auckland, in New Zealand, was the first person to identify this condition, and he said, okay, we can do the amniotic fluid testing. But then they found out that this amniotic fluid OD at 450 is only of value in hydropic fetuses, and in non-hydropic fetuses it has a negative correlation, which means when you find delta OD at 450 in zone 1, 2, or 3, this baby is already severely anemic and more likely to die. So the problem was you were diagnosing it too late. So that was what changed in the year 1995. This person called Mari, what he did, he said, when the baby is anemic, the blood becomes less viscous. And because of less viscosity, when the fetal heart pumps the blood flows at greater velocity through the middle cerebral artery. And this was a very remarkable thought process. And then this came up at that time, it was published in 1995. It had 100% sensitivity and a 95% specificity. So that was what Mari published in 1995. And then slowly people realized it's now about 86% sensitivity. If you use MCA peak systolic velocity at 1.5 mom as a threshold for diagnosis. But nevertheless, it is still the best method of identifying non-invasively fetal anemia. So a simple rule of thumb is you take the gestation age in weeks, let's say she's 25 weeks, then if the MCA PHP double that value, more than 50, then that's automatically more than 1.51. So even if you don't have a chart with you, then if you say she comes at 26 weeks, let's say the MCA PHP mom is about 60, then you say this baby requires immediate treatment. Now, the absolute hemoglobin before which hydrops develops varies with gestational age. and a HP of less than 0.55 mol correlates better, and fetal hemoglobin of less than 7 grams. So this chart will actually give us about the norms and according to the gestation age, and we can plot it. Now, MCA PSV greater than 1.5 mol predicts moderate to severe anemia and high drops, and MCA PSV less than 1.5 mol is very reassuring that the baby is unlikely to have anemia or may have mild anemia which does not require treatment. But when you do the ultrasound, we can also find out suspect anemia in the baby by doing ultrasound. One is polyhydramnios because baby has a hyperdynamic circulation, so increased renal blood flow and causes increased urine output. Second is cardiomegaly, again because there's a rapid circulation, the return, cardiac return is very high. The baby has splenomegaly, obviously because of hemolysis, extramedullary erythropoiesis is taking place, so fetus has splenomegaly, placentomegaly, hepatomegaly, and also ascites. And turbulent flow in the portal vein, and also MCA systolic velocity. And when you do the MCA, you can find that has a small double peak here. We call it as a dichrotic notch, and it's very, very significant in fetuses with anemia. But we can talk about MCA, but remember, a proper technique is absolutely vital, where the angle of the measurement that is taken has to be between 0 and 20 degrees, and inadvertently take the angle at a different angle, then the velocity measurement will be different and wrong interpretation will be done. So technique is very, very important. Now let's move on to case 2. She is a gravida 3 para 2 RS negative pregnancy. First male child, baby blood group was O positive, so anti-D was given. Second was a stillbirth, and ICT status was not known. There was no history of postpartum hemorrhage, but anti-D was actually given, and she comes for the third pregnancy. And at 25 weeks, growth was normal, Leica was normal, but Leica was showing polyhydramnios, and suddenly the MCA PHP shot up to more than 1.5 mol. It is repeated in 2 days' time just to say whether it's an error of measurement, and it went up to 1.7 mol. Within 2 days, it went from 1.5 to 1.7. So this required an immediate transfusion. So the treatment for anemia is intrauterine transfusion, and it is the most definitive treatment for fetal anemia. And on all fetal therapeutic procedures which have been done till now, from the beginning, the most successful form of fetal therapy is intrauterine transfusion with the highest success rate and the best fetal outcomes, long-term outcomes also. Now, it is done between 18 weeks and 35 weeks. We can do intraperitoneal or intravascular, but the first choice will be intravascular. Now, the first intrauterine transfusion was done by Professor William Liley. No ultrasound was available. It was in 1963, and imagine what he has done. He has put in a what's called as a Cohi needle inside the fetal abdomen, and then introduced a catheter and injected a dye, right? And this dye on the X-ray showed where he was there, the sweet space. So ascertaining that he was in the peritoneal cavity, he transfused the blood. And this baby, because she had already lost 3 babies, 30 weeks he did this transfusion, and this baby actually survived. And they had an 80% mortality rate of hemolytic disease or newborn in those times. And when this baby survived after this procedure, tremendous increase of generated. Then intraperitoneal transfusions were given to neonates even before that, 1958, 61, and all that. But they said the rate of absorption is not very good, it's not predictable, so they were not thinking too much about it. I believe, like I said, doesn't matter, we'll still go. Even if I can save 1 baby, we can save. And that's how intrauterine transfusion started. Today, we plan for intrauterine transfusion by doing intravascular transfusion. We don't do routinely peritoneal transfusion, only as an addition in some selected cases. But for this, we need a donor blood. And this is where the blood bank becomes extremely important. We need fresh O-negative blood cell, less than 5 days old, washed packed cells with a hematocrit of greater than 80%, irradiated to avoid graft versus host reaction, CMV negative, and it is cross-matched with the mother's blood. So we send mother's blood for cross-matching. Then somebody came and asked, why the mother herself has the blood, she can give it to her own baby, because there are some people whose religion does not permit somebody else's blood to be given. So these mothers, when they come, they can become donors, but there are some caveats for that. The mother can be a donor, but it's not routinely done because many of these mothers themselves will be quite anemic. And blood is collected prior to the procedure and goes through the whole usual process, but it has to be cross-matched with the fetal blood. It's not with the, because we are cross-matching the donor's blood with the mother's blood and giving to the fetus, but here you have to cross-match directly with the fetal blood for it to be given. Now the process of transfusion is first we do fetal immobilization by giving an intramuscular injection of pancuronium or velcrolim, and then we put a 20 gauge needle into the intrahepatic portal vein, and then you attach a 3-way and connect the vein. So here is the transfer of the abdomen with the intrahepatic portal vein, the needle in the portal vein. You can see the blood being pushed inside, which is called as the cascade. Constantly we visualize, you can see the fetal heart in the abdominal aorta. We can also use the umbilical cord through the at the point of entry the placenta, which can be there. And another possible thing is the free loop of the cord, which is something which we don't prefer. There are people who have done it, but we don't prefer this because once you put a needle in the free loop of the cord, you can see what happens. The blood ooze once you remove the needle, the blood starts oozing out, though it will stop in about a minute or so. So you use a 3-way syringe to slowly, because it's a very high hematocrit, you need to inject it slowly. You can't inject it too slowly also because the needle will get clogged and you won't be able to do. But at the end of it, you can see the MCA systolic velocity has significantly come down and the anemia stands corrected at this point. Right. Then, so pre-transfusion, post-transfusion, you can see the difference in the historical CRT, middle cerebral artery. Now, what do you do later? Can one transfusion be sufficient for the baby to go and deliver at what time you go? But since we are giving the donor blood has got a finite life. Second, there are also antibodies which are being continuously transmitted, and the fetus is also producing itself. Those will get hemolyzed. So a constant hemolysis is taking place, and breakdown of the adult RBCs also taking place. So there will be a decline in the fetal hemoglobin after doing that. So we call them back in 2 weeks' time. We look at the MCA-PSV. They have a usual fall of hematocrit is about 0.8 to 1 per day, and a retransfusion will be needed around 3 to 4 weeks or so. So depending on when to start, a baby may require 1 transfusion, 2 transfusions, or 3 transfusions. The maximum number we need to give for a baby is about 4 transfusions when we start very, very early. But when you do a repeat transfusion, the MCA systolic velocity of 1.5 mom will not work because you have given a very high hematocrit blood and the viscosity of the blood is much higher. So what happens is you have a separate cutoff for it and go to the 1.69 mom. Then we plot everything on what is called as the transfusogram, where you can see the as the MCA increases. So we have done a transfusion here. Immediately the MCA is dropped down, then gradually increases. Further transfusion goes down, and then gradually increases. Then by the time she has come to 34 weeks, 35 weeks, we can deliver the baby. The last transfusion is given at about 34 to 35 weeks. And if the baby is stable, you can deliver by 37, 38 weeks with anti-natal steroids and elective LSCS or planned vaginal therapy also can be done. So the outcome of this particular baby was 35 weeks and 4 days she delivered. She had reduced fetal movements, female baby weighing 2.2 kg, and HP at birth was 11 grams, and the baby did not require, and required some phototherapy, but did not require any exchange transfusion. So one of the advantages of doing a date transfusion is the number of exchange transfusion, babies requiring exchange transfusion in the neonatal period will actually go down. So that's an advantage. But look at this patient. So now we are going to ask ourselves, how severe an anemia can be treated? Or at some point you say, let's let this pregnancy go, and next time we will restart all over again. And here is a very significant anemia with a large placenta, high drops, cardiomegaly, severe tricuspid regurgitation at 25 weeks, and the hemoglobin of baby was only 2. Hemoglobin of baby was only 2, and 74 ml was transfused. Post IUT pH was 1.21, and at 26, 27 weeks, you can see the ascites has disappeared, the cardiomegaly has come down, the polyarteritis also has come down, and at 32 weeks, there was a rising trend of LCA again, re-evaluated, it went to 1.7 and another transfusion was given, and the electricity then set for 36 weeks. Now, important here is the postnatal baby blood group. Postnatal baby blood group will be O negative. I remember in the early days when the neonatologist called up and said, baby blood group is only O negative. Why was the need for you to give an interaction transfusion? So they were all surprised because this I'm talking about 15, 20 years ago, we started with the transfusion. Then say this is the blood which we have given. The baby own blood. The bone marrow of the baby gets suppressed. It stops producing cells, and only the donor blood will be there as negative. It takes about 3 months, sometimes even up to 5 months, for the baby's original blood group to come back. So sometimes top-up transfusion will be required. Now, perinatal survival after interaction transfusion in non-hydropic fetuses is 90 to 95%. In hydropic fetuses, about 85%. And the important thing is, what about long-term outcomes? Neurodevelopmental outcomes. Overall neurological impairment is about 4.8%. The major risk factor is for fetal hydrop. When there's very severe anemia, sometimes the baby can have hearing deficiency. So what we do is after all these babies who undergo intrauterine transfusion, definitely require a BERA test once they reach the level of maturity to keep early intervention as required. Then I will tell about a little bit about can we prevent this from happening. We have said prophylaxis, but this lady is already sensitized. Can I reduce the severity of the anemia, or can I postpone the transfusion? What can I do? The role of IVIG in alone pregnancy. The IVIG blocks antibody-mediated destruction and reduces placental transfer of antibody. It delays fetal anemia and postpones the first intrauterine transfusion. This is an alternative to invasive procedures in severe cases less than 20 weeks, but it is not routinely recommended. IVIG is extremely expensive. You have to give it every week from very early pregnancy onward, like 12 weeks onward. You have to keep giving it. But in India, the All India Institute of Medical Sciences have published a paper on that. And as I said, it is limited to those cases where, because of several RH isomerization pregnancies, she comes and then 16 weeks of son has already hydros. So very severe. But with every pregnancy, the severity will become more and more, and the process will start earlier and earlier. So in such cases, it might help. But that's future trend, and that's holds a lot of promise, which is the drug called nipocalimab. This nipocalimab is right now undergoing a phase 3 trial, and what they have shown is live birth after 32 weeks of pregnancy with intrauterine transfusion in historical controls is 10%, and in the study pregnancies is 54%. It means in a huge number of patients, they have been able to avoid an intrauterine transfusion by nipocalimab. And no intrauterine transfusion, extreme transfusion or simple transfusion of RBC needed in 46%. So this is something very, very promising, but hopefully the trial has to be over and the drug has to be there. So what it does is it goes and it lowers the maternal blood IgG levels and also prevents transfer to the baby. A few words about non-immune anemia before I close. Chorioangiomas, fetal infections like parvo-RSV-19, intrauterine hemorrhage, fetal-metal hemorrhage, baby malformations, leukemia reactions, and tricyclic are all causes of non-immune. I've just given a partial list here. So here's the case of a large chorioangioma, which is given a very, very vascular chorioangioma. You can see in the 3D that it's a placental tumor which is jutting out of the placenta. You can see one large vessel in this 3D picture supplying the chorioangioma. So what happens here is it acts like an AV malformation. It causes anemia, it causes cardiac compromise, severe tricuspid polyarrhythmia, preterm labor, and also it can cause maternal mirror syndrome. That's why they need to be treated on an urgent basis. We do give intrauterine transfusions if the MCF is greater than 1.5, but sometimes the transfusion itself can control the system. We can undergo spontaneous aggregation vascularity, but then you might have to, it's temporary, and a repeat transfusion may be required. So what we definitely treatment here is we do several procedures. One is called the interstitial laser. So I'm putting an 18 gauge needle here and threading a laser fiber through that into the choriogram and going all the vessels which are there. The second thing is also, if you find a large vessel which is going inside, I can access the vessel and inject histacryl glue. This histacryl glue mixed with lipiodol. As you inject, immediately it gets solidified and block the entire vessel. And this is a very, very effective treatment for a choriogram required treatment. The last method which we can do is, supposing it's a posterior choriogram and you don't have access to any of this, I can put in a fetoscope. This is a fetoscope which I'm putting in, identifying the supplying vessel there, and I'm lasering that vessel so that it completely occludes. So these are several methods which are available. Now, congenital CMV infection, it's more common than what we think, but less identified. And in this particular case, you can see a huge hepatomegaly and splenomegaly, and a high velocity flow in the duct spinosa to be also anemia. But we don't go and transfuse baby with CMV infection with intrauterine transfusion, mainly because the baby is already severely affected, that the outcome is going to be very poor. On the other hand, if it's a parvovirus infection, then it's worthwhile doing a transfusion, because parvovirus is a very self-limiting disease and it will not progress further and it doesn't cause any fetal damage. So it just causes severe polyhydramnios and anemia, and if you tell about the price, this baby has got a good chance for good outcome. And here's the baby with came suddenly 29 weeks sudden loss of fetal movements, and you can see inside the brain there's an ecogenic area which is because of intracranial hemorrhage, and this has caused deep behavior reversal in ductal stenosis and loss, and the baby could not be salvaged. But let me give you one very interesting case study here. This came to us O negative, routine target scan ICT was negative, MCA was quite normal, and she comes back only at 36 weeks. She said everything is normal, come back at 36 weeks. At 36 weeks, MCA PSP was 109 centimeter, which is almost too long. So is it non-immune anemia? Well, whether it's fetal hemorrhage, parvovirus infection, AP1 compatibility, any other causes, hemoglobinopathy, suddenly a whole host of differential diagnosis comes to our mind. So all we did is a Clive-Becky test in the mother, and that took be negative. So fetal blood sampling was done. So there was no fetal hemorrhage. Hemoglobin of 9.8 grams. Direct chromosome also was negative. Fetus was O positive. Total leukocyte count was normal. HPLS was normal. Everything was normal. Indirect chromosome was also negative. And so what happened ultimately? The cause for the anemia would only be diagnosed in the after birth. But by the time you get to the baby, this baby already had intrauterine disease. All happened within a very few days. Now, this 29-year-old GDM on metformin came to us with reduced fetal movements, screening ultrasound showed high drops, referred for second opinion, again MCFP, PSP 2 more, and IOT was not 2 hours of the procedure, but hemoglobin was 1.3. But here we did the maternal Clive-Becky test and found positive. So you can see the huge number of fetal cells in the maternal circulation, and indirect chromosomes was negative, blood group was O positive, and here on this was an autopsy which was done showed diffuse villitis, total calcification. So here was a massive fetal hemorrhage. If the fetal hemorrhage is shallow, we still have time where we can go and do an intrauterine and save the baby, because otherwise they are quite normal. So the last thing is, here's the 32-weeker who came with lots of fetal movement, and suddenly we find NCAPSV is very high. Final diagnosis was Down syndrome, and this baby had what's called a leukemia reaction, massive, severe anemia, but had leukocyte running. So this was because Down syndrome can be associated with trisomy 24. So I'll leave you with some take-home messages. MCFPSP greater than 1.5 mom is indicative of fetal anemia requiring intervention. So that's our point. Effective universal anti-D prophylaxis helps prevent hematologic disease of fetal newborn. Several causes of non-human anemia are recognized. Treatment depends on the underlying cause. Intracranial transfusion is a safe and life-saving procedure, and a need for a O-negative donor pool to get fresh blood on an urgent basis. Because many of them travel from various parts of the country and they come here, they don't have time to stay, to go and find the donor, fresh donor, take it, feed it. And in this, I have to say a word that from the very first day, we started intracranial transfusion in the year 1995. 95 we started the first time, and that boy who was delivered is now getting married, and and to take it that they were just a food sellers in on the road, road vendors, and this boy not only do that, we supported him for his education. He now finished his catering technology and he runs a very successful business. And we have for to say the outcome, we have a 27-year outcome to say that this actually works. But more importantly, the first person I came and asked for giving blood for the baby is to Dr. J. Balsamon. And he said, okay, no problem, we'll give it to you. And then sir, I said, I need high hemoglobin. Because those days when you say fat cell, only the blood will be decanted, the soup will be taken off, and the rest on for fat cell. Then we needed what is called double pack. We need to compact a little more. Then I actually had 1 or 2 cases we diagnosed, and there with him, he was able to give us high quality. Until today, the only blood bank I've done for all our close to 300 transfusions is PHL blood bank. And we get somehow they will get a donor, and Maitri won't be one for me. So thank you very much for a patient listening, and thank you for the opportunity. I'm truly honored by this.
Thank you for the wonderful oration, sir. And I can see from the face of our audience that they are brimming with the knowledge of fetal. And I would like to welcome Dr. Purna Chandran sir, our current director of VHS. He is an analyst, healthcare administrator, and external assessor for ADH, QAI, and national quality assessment programs. He has a strong interest in quality, patient engagement, hospital management, and healthcare design. With 29 years of experience, he has served as an anesthetist and medical administrator in several leading hospitals across Chennai. It's our privilege to have you with us, sir. I would like to invite him to share a few words.
Thank you very much. It's nice, wonderful oration. This is my first program in VHS applied to it. I'm sorry, I was a bit late. I was interviewing, that's why I didn't get it's quite interesting to go after discussions. Then, finally, he said, he has helped the community. That's our purpose. I want we should make this stronger and we should make it bigger and bigger. That is condition. Requesting all of you supporting this journey. Thank you very much.
Thank you, sir. Sorry for taking the floor of a function. In between, we would like to present a small token of appreciation for our blood bank team members for their punctuality and the dedication towards the blood donation camp. And we have identified 2 members of our blood bank team, and I would like to call upon Mrs. Bharati, who is a senior staff nurse of VHS Blood Bank, and Mr. Balaji, who is a lab technician of VHS Blood Center. I request both of them to come forward and receive a token of appreciation. I would like to request Dr. Maitri ma'am and Dr. Suresh to present.
We are giving this, we are honoring them because they are very punctual in the camps. And so we have to go as a team for any camp. So we have to be very punctual, otherwise we'll get problem at the campsite. So we have to start sometimes at 7 o'clock in the morning, sometimes evening come late by 7 or 8 o'clock like that. So the blood bank getting blood units is very difficult, and we are honoring these two people who are very punctual at the time, even it is 7 o'clock or 6 o'clock, they're always on time, and for that purpose we are honoring them. Thank you.
One more person we identified as Mr. Nagakumar, who is our attendant, but since he is in a night duty, I would like to call upon Mr. Balaji to collect the token of appreciation in his absence. Thank you. So I would like to call upon Mr. Atmanand sir to convey the oath of thanks.
Good evening, everybody. At the outset, I have thanked Mr. Director of Mediscan Systems for his wonderful presentation on diagnosis and management of fetal bleeding. Though 90% of whatever he said went over my head, but I am not a medically qualified. We go back to that. The topic very closely is obviously it was a great presentation. I thank Professor Subhash, Professor at Head Department of Transfusion Medicine, MMC Chennai, for agreeing to be the chief guest for this session. When Dr. Nithya and I went to invite him for this occasion, he accepted our invitation without fuss. Thank you, Dr. Subhash, once again for your invitation. I thank Sri R. Rajagopal, Managing Trustee VHS, for choosing to be with us in spite of another important task he has today. Thanks for that. I thank Mr. G.P. Ramachandran not only for the funds provided for this occasion every year, but also for the active interest he takes in the function of the blood bank, in the function itself and its details. I thank Dr. Revataraj, who is not here, for effective comparing she has done today. I thank Dr. Purnachandran, Director VHS, Dr. Maithili, and Dr. Nithya for their active participation in today's event. I thank Mrs. Vijay Lakshmi and Mr. Gopinath in VHS for their support in organizing the event. I thank Mr. Sudha, Principal of Nursing College, and Mr. Bharat for the silent support we got from them. I thank all my colleagues in Blood Bank and in Thalassemia Welfare Association for their active and continued support. I thank the vendors, Chella Caterers, Vignesh Confits, and the pages for member flow and citation. Thanks all of you, and I don't want to stand with you and your highly rating outside. Thank you very much. Once again.
Thank you, sir. I would like to ask everyone to rise for a national anthem.
जय हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone. Please do join for the high tea and have a pleasant evening ahead.